Let me introduce my PhD topic, which is investigating the risk factors and therapeutic approach of medication-related osteonecrosis of the jaw. My name is Sára Borbála Szabó, and I'm an oral surgery resident and a first-year PhD student. My supervisors are Réka Fazekas, Fruzsina Kis, and my scientific methodology supervisor is Lőrinc Frivaldsky. My vision is prolonged survival and improved quality of life in patients receiving bone-modifying agents therapy. And my mission is to estimate the risk and rate of medication-related osteonecrosis of the jaw in patients receiving bone-modifying agents therapy. I have two ongoing projects. The first one is a systemic review and meta-analysis, which we started last year in September, and the second one is a prospective observational study, which we started in November last year. The title of my first project is Investigating the Efficacy and Safety of Anti-Angiogenic and Anti-Resorptive Treatments in Bone Cancer Patients. A little bit about the background. Approximately 2 million patients have been diagnosed with cancer in the USA in 2024. With the prolonged survival of these patients, bone metastases frequently occur in association with solid tumors like breast, prostate, colorectal, and renal cell cancers. If we look at the treatment options, anti-angiogenic drugs block the growth of blood vessels that support tumor growth. On the other hand, anti-resorptive drugs such as bisphosphonates and denosumab are used to prevent and treat skeletal-related events like pathological fractures, bone pain, and hypercalcemia. As I'm training to become oral surgeon, I'm concerned about the oral complications caused by these drugs, which is medication-related osteonecrosis of the jaw. This is a severe, painful condition, decreasing the patient's life quality. The incidence ranges from 1% to 10% in patients who were previously exposed to anti-resorptive drugs. With the addition of anti-angiogenic drugs, this percentage increases. However, there is a lack of information in the literature regarding the accurate incidence of this condition after combined therapies. Therefore, our aim is to reach a definitive conclusion on the efficacy and safety of these combined treatments in comparison with their separate administration. Our clinical question is, does combination of anti-angiogenic and anti-resorptive therapies increase the efficacy without enhancing the side effect profile in bone cancer patients? Our population is bone cancer patients, primary and metastatic. Our intervention is anti-angiogenic and anti-resorptive therapies. Our first comparator is anti-resorptive therapy alone. Our second comparator is anti-angiogenic therapy alone. Our efficacy outcomes are overall progression and fracture-free survivals, and our safety outcomes are medication-related osteonecrosis of the jaw, gastrointestinal, and skin side effects. Our hypothesis is anti-resorptive and anti-angiogenic therapy in combination improves the overall survival and does not cause more side effects. And our clinical or research implication is better survival and improved quality of life in bone cancer patients. Here you can see our search key. The first domain is about the population. The second one is about the interventions and comparators. We conducted this search key in 5 databases. With the main selection, we found 13 articles eligible, and with citation chasing, we added 3 other ones. We are currently finished with the data extraction, and we are at the risk of bias assessment phase. The title of my second project is Investigating the Resolution of Medication-Related Osteonecrosis of the Jaw, which is the registry analysis project. As I mentioned, medication-related osteonecrosis of the jaw is a severe, painful condition, decreasing the patient's life of quality. It can be characterized by exposed bone that can be proved through an intra- or extraoral fistula in the maxillofacial region, mucositis, and impaired wound healing. The management is quite challenging and case-dependent. Here you can see the 2 main ways, which is conservative and surgical treatment options. However, 20 of these patients remain with persistent symptoms, so our goal is to aim to assess the early diagnosis and control of the course of the condition. Our clinical question is, what are the optimal treatment paradigms in different stages of this condition. Our population is the stages of this condition. Our intervention is combined surgical and non-surgical therapy. Our comparator is non-surgical therapy, and our outcome is time course and rate of resolution. We have two hypotheses. The first one is surgical treatment in combination with medical therapy offers more predictable results than non-surgical therapy alone in all disease stages. Our second hypothesis is the rate of resolution of medication-related osteonecrosis of the jaw is related to the severity and stage of this condition. Our clinical or research implication is characterizing treatment patterns for medication-related osteonecrosis of the jaw to improve the patient's quality of life. Our inclusion criteria is any able-bodied patients over the age of 18 with newly confirmed medication-related osteonecrosis of the jaw. Our exclusion criteria is patients under 18 and the patient withdraws their voluntary consent during the study. Here you can see the centers we plan to include, and this will be a national multi-center registry. To summarize our two ongoing projects, we plan to submit the first one this year until September and the second paper until 2027 February. I would like to finish my presentation with a quote from Charles F. Kettering: "Research means that you don't know but are willing to find out." Thank you for your kind attention.
Thank you for your very nice presentation. It is a nice topic. My question is, when in your first project, when you include the patients, what do you mean exactly by bone cancer? Are those patients with metastasis from a primary cancer?
We would like to watch the patients who have primary bone cancer, like multiplex myeloma or giant cell tumor of the bone. And the main articles we found had the population of metastatic renal cell carcinoma. So they had a solid tumor first, and then they developed bone metastasis. But we would like to assess both.
Okay, so both of them. And the question is, don't these patients have clear guidelines on the therapy? I mean, most probably their diagnosis is going to determine whether they will get anti-resorptive and anti-angiogenic drugs.
Yes, we have found some different guidelines. They usually get anti-angiogenic drugs for the solid tumors, and then they get a combination therapy because they get anti-resorptive drugs too, because they want to prevent the formation of bone metastasis and pathological fractures and so on.